Hello and welcome to Health Live at Seniors Today. We are delighted to have here with us today Dr. Vishal Chafale, and we have requested him to speak on the all-important issue of Alzheimer's disease. A little about Dr. Chafale before we start. Dr. Vishal Chafale is a highly regarded neurologist with extensive experience practicing at the Apollo Hospital, which is in Navi Mumbai. With years of expertise in this field, Dr. Chafale specializes in treating a wide range of neurological conditions ranging from stroke and prevention to headache, epilepsy, Parkinson's, and neuromuscular diseases. Dr. Chafale's knowledge and experience enable him to provide precise and effective treatment to his patients. He understands that neurological ailments can manifest in various ways, from minor headaches to complex disorders. A graduate of several well-known institutions, and he holds degrees in like the MBBS, MD, DM in neurology, and DNB. Dr. Chafale has earned a fellowship for interventional neurology, showcasing his commitment to advancing his expertise and providing the highest standards of care to his patients. Welcome to Health Live at Seniors Today, Dr. Chafale.
Good evening, everybody. Thank you. I'm sharing my screen.
Yeah, so we've requested, as I mentioned, Dr. Vishal Chafale to speak about Alzheimer's disease. He will make a presentation, and as he starts his presentation, those of you who have questions, please put them in the Q&A tab. And as always, we will take the questions later. Over to you, Doctor.
Yeah, good evening, everybody. Today I'm going to discuss rather than speak about Alzheimer's disease. This is one of the common form of problem in elderly. As we are seeing now, our in India itself, in the world also, overall our aging population, our population is aging because of advancement in the technique. So we get more and more cohort of the people who are now more than 70 years, 80 years. So similarly, though, that's why the problems which are common in elderly, we are seeing in more common in our nowadays practice. So Alzheimer's disease is one of these problems, and it is quite frequent, and sometimes it is neglected, sometimes it is undiagnosed, and that's how it is. So dementia is actually, it is one of the dementia. I would say it is one of the common type of dementia. What is dementia? Dementia is forgetfulness. Our capacity of the brain to of reasoning, of calculation, of to retain something, to form new memories is affected in the dementia. So there are a lot of type of dementia. So the cognitive function, brain maintains our cognition. So what is cognition? It is a mind, brain function that makes us aware of the object nearby, our thought perception, and it helps us in thinking and remembering. So whole this process is happening in the brain. It happens predominantly the left side of the brain because it is dominant. Those who are right-handed, all parts of the brain are important. So they have different lobes and they are connected, like frontal lobe, parietal lobe, temporal lobe, occipital lobe. They have their functions, and ultimately they work in a synchrony, and they are connected, and ultimately they give us this function we call as cognition. So ultimately when this is affected, this cognition is affected, when the formation of the new memory is affected, so and if it is affects our day-to-day functioning of life, then we label it as a dementia. Dementia is it's an acquired problem. It's not, nobody is born with a dementia. It is generally acquired. So there is a impairment in the intellect, memory, and personality. But patient remain conscious. Like I'm conscious, suppose I'm sleepy and I'm not able to, due to some reason, and I'm not able to perform my higher mental function activity, then I will not label it as dementia. I am conscious, but still I'm not able to perform those demanding activity. Then I will label it as a dementia. And especially in our clinical practice, suppose somebody is having this problem and it's of sufficient magnitude and ultimately it impairs his day-to-day activity, then we label it as a significant, and it is, we call as dementia. Otherwise, we label it as a minimal cognitive impairment, and we follow this individual, and we take it further. Sometime for years they remain in the same range, and we give some memory boosters, and we treat them. So Dementia, it will not occur overnight. It will be, it is slowly progressive. Whenever start of the process, nobody is able to diagnose when it starts. So by the time you know the symptom, it's already a significant proportion of the brain neurons are already lost. So it is a neurodegenerative process. We have a compensatory mechanism in the brain. Suppose my 5% of neurons are lost. Still, I will not have any symptoms because 95% is functioning and it will take care. 10% is lost, 90 will take care. I will not have significant manifestation. But at certain point of time, you will have symptoms of those neuron loss. So we call it decompensation. And that's when you start noticing features of the dementia, forgetfulness and all. So by the time we notice the features or first symptom, I would say the process already have started few months or at least a year ago, and we are getting these manifestations. So whenever a person of a cognitive impairment or forgetfulness come to us, our aim is not to diagnose dementia or Alzheimer's. Our aim is to diagnose something else so that we can do in different way, we can treat them in different way, and we cure that problem. So we try to differentiate dementia, a person with forgetfulness, with primary and secondary dementia. When I call primary, I try to investigate other causes, like sometimes there can be some stroke in the brain, in the memory area, and person may have dementia. And suppose I give some medicines, and with recovery, their cognition may improve. Sometimes some deficiencies of some minerals, sometimes gross vitamin B12 deficiency, sometimes untreated thyroid, sometimes electrolyte imbalance, sometimes subdural hematoma in the brain, some tumor growing in the memory part. They may also give the similar features like Alzheimer's disease, and we have to separate them. So our aim, as a neurologist, we try to find out these secondary dementia, secondary causes, so that we can treat them and we can prevent them for worsening. So this is how a person comes. Then we once we know that there is no secondary cause, then it is a primary dementia. Then we investigate. So we label that person. Where there are different types of primary dementias also. Alzheimer's is one of the common dementia. Like Alzheimer's in India, we have dementia with Lewy bodies, DLB. Then we have Parkinson, advanced Parkinson person will have dementia. Then we have frontotemporal dementias. And these are other types of dementia also we have. So we use our different clinical tests, and we diagnose such person. Suppose I diagnose a person with Alzheimer's disease, then what is this? Let us discuss this, one of the common type of dementia, Alzheimer's dementia. So it is a chronic problem. It is irreversible. It affects the cells of the brain, and ultimately it causes impairment of intellectual functioning. So this is Alzheimer's disease. When I say chronic, again I mentioned, by the time a person is diagnosed or detected to have a dementia features, the process of dementia already have started few months or at least a year before. That's why it is a chronic. And ultimately, whenever we diagnose, it's not like that is the end of this thing. Again, it will have a lot of years progression slowly. Sometimes it is slow progressive. Sometimes some people may deteriorate rapidly, or illness may also cause worsening of the symptom. So it is a chronic. And when I say irreversible, means somehow the neuron loss, whatever loss is there, it is there. And it will give some symptoms. So it is irreversible. Ultimately, a person with dementia, they gradually they lose the capacity or ability to reason, remember, imagine, and learn. And these are the domains ultimately they affect, and they get the symptoms of due to all these things. What are the causes? If we say that any particular cause for dementia and I avoid it and I can treat it, then it's well and good, but actually it is not. Most common risk factor or cause is age. As age advances, the risk and prevalence of the Alzheimer's or any dementia will increase. Similarly with the Alzheimer's. Then family history. Less than 10%, I would say less than 5% of the Alzheimer's people, they will have family history. So that cohort is something different. Now, when we see Alzheimer's, it is generally a problem of the elderly, like more than 70, more than 80, we see more and more. When I say it is a genetic or familial form of Alzheimer's disease, they are very young. Means less than 60 years, like in 55, or sometimes less than 50 also, they may start features of dementia. It's not common, it's very rare, but it's a it's a genetic actually, rather than family genetics. Family history actually it is a I will say multifactorial. Like somebody is having diabetes, so it doesn't mean children will have diabetes. It will mean that children will have high risk of diabetes as compared to normal population. Similarly, those who have family history of dementia, Alzheimer's, will have increased risk as compared to other population, as compared to other population of developing dementia or Alzheimer's like features. Then there are certain modifiable risk factors like hypertension, if it is uncontrolled, then dyslipidemia, lipids, then uncontrolled sugar, some are like smoking, excessive drinking. They affect our cognitive function. So they become modifiable risk factor. So whenever a person of a dementia comes, we try to find out other risk factor which may progress or may worsen his cognitive ability. So we call them modifiable risk factor. And certain medical condition like Down syndrome, a person with Down syndrome will have more of a chance of developing Alzheimer's. Then a person having a recurrent stroke. Then those who have multiple past history of or significant head injury. So these are the medical conditions which make a person prone for dementia. So it is generally diagnosed in elderly. When I say elderly, is more than 65 years. Early onset, less than 65, it is very uncommon, or I would say less than 5 to 10%. 1 in 6 women and 1 in 10 men over 55, that is Alzheimer's, and they will ultimately develop dementia. That is actually it's very significant. 1 in 6 means almost 20% of women. So it is significant percentage. Now, incidence about 3% of men in 65 to 75, 74, they will have dementia. Suppose we follow them or we examine them. And suppose I examine an elderly male, octogenarian more than 85. So this percentage will be around 85, almost 50%. So everybody will not be symptomatic or they will not be impaired in a cognitive impairment. If I examine them, I may find a mild dementia and like that. So this percentage is around 50%. So it's significant. So age is a risk factor. So it is a problem of elderly. What happens in the brain? Why the dementia develops? So it is extensive, actually, the research going on in this, because ultimately the burden of this disease is significant, and it significantly gives the burden on the caregivers and also the economy. So there is significant challenges with this disorder. So a lot of research is going on, and pathology wise, actually, there is a deposition. There is ultimately neuron loss, and there is a deposition of neurofibrillary triangles. So they are generally they are the damaged remains of the microtubules and the twisted nerve fibers, and they deposit in the part of the brain. And slowly, that part of the brain will get destroyed. Some neuron cell get damaged. Predominantly, the memory area is affected. Memory area is in temporal lobe. So that's why Alzheimer's people will have more of a memory features. They do occur, affect the frontal lobe. They do occur in the parietal lobe, but predominantly temporal lobe, parietal lobe, then frontal lobe. So these are the different areas they affect. It is variable. Sometimes all lobes are equally affected. Sometimes we have more of a frontal lobe involvement than memory area. So that's how the symptoms will vary. Once significant loss occurs, then we start developing the symptoms. So if I do histopathologically, so these are the tangles. You can see neurons, there are tangles. So ultimately they damage the neuron cells, and there are also amyloid plaques. So the vascular risk factors like those having uncontrolled hypertension, diabetes, uncontrolled other risk factor like smoking and all. So they will have more of this plaques formation. So we can actually prevent the progression of the dementia or reduce the risk by avoiding this amyloid plaque formation, not completely, but to some extent. So this is what the brain looks like. This is actually pictorial diagram. You can see the healthy brain. You can see that There is no significant brain spaces. It is there, but once in Alzheimer's, advanced Alzheimer's, you can see that brain is in small size. It has shrunken in size, and you can see the cavities of the brain, sulci, gyra, they are more prominent. This is the brain of a healthy person, and this is the brain of a Alzheimer's person. So there is ultimately neuron loss. So volume is also low. This is what we get in MRI. You can see healthy MRI with normal brain spaces, normal sulci gyra. In dementia or in Alzheimer's, you get this type of picture where the brain cavities are more prominent because of neuron loss. As I mentioned that extensive research is going on. So in 2014, the Nobel Prize, in fact, was into the scientists who were working in the cognitive and Alzheimer's domain. They got the Nobel Prize also. So this is called as worst plaque, whatever the amyloid plaque, neurofibril tangles of the 21st century, because still it is unsolved. We don't have anything now significantly that we target that plaque formation as of now significantly. That is a problem. It is still area of investigation and extensive research is going on. What are the environmental factors? Sometimes recurrent infections, then metal and toxins, then excessive amount of metal ions such as zinc and copper in the brain. Then there is a deficiency of certain vitamins B6, B12, and folate. These are some environmental risk factor for the dementia. Now coming to the clinical features, how we diagnose or how we see a person of the Alzheimer's disease. So actually in elderly, what happens? We don't expect them to do a lot of higher functioning. So they may have some features of the dementia, but day-to-day life is not affected because of those higher function. So by the time the elderly family notice the function or features of dementia, by the day that already it is at least a mild to moderate stage, they come us. So what are the changes you should look for a person is having dementia? Not only Alzheimer's, other dementias also. So you will see the personality change. They will have lack of interest in day-to-day activities. They have easy mental fatigability. They are generally withdrawn, self-centered, and ultimately they don't take care of themselves, like neglect food, neglect their hygiene, proper dressing and all. It will not be there. It's in advanced state, but these are the subtle features. Sometimes in day-to-day activity, we may find these are personality changes. Then in memory domain, we can see that recent memory is generally affected. We call it episodic memory disturbance. They actually forget some episode. Like suppose you have given the breakfast. In afternoon, they will say, no, I have not taken breakfast because they are not registering the whole episode of the breakfast. That is called as episodic memory disturbance. They may remember something which has happened remote past, like in 20 years back, I have taken that breakfast. They will nicely describe everything, but they will not able to describe what in morning they have taken. Because the older memory, the past memories, they are well formed. There are well formed circuits, and that's why they remember them. But episodic, that recent memory formation is a problem because new circuits, they are affected and they don't form properly. So that is a problem with Alzheimer's. So recent memory is affected, episodic memory predominantly in recent memory. Then they will be disoriented. Like some in advanced dementia, they may not be able to see whether it is morning or evening. Sometimes disorientation, like they are whether on first floor or ground floor. Then judgment issue will be there initially. When they have difficulty in abstract thinking, some regional reasoning of some particular problem, and they will have reduced attention plan, lack of concentration. So these are the subtle features also. And with as a disease advances with few years, you may get more and more features. Sometimes there can be a behavioral feature. This becomes very difficult. So normally Alzheimer's people, they will be very calm, quiet. They will be sit nicely. They will come. They will deny that they will have anything. They see that family members are just coming with them and they are telling that dementia is having. Because they are forgetting actually they have dementia. But in behavior variant of dementia, it has become difficult. They are slightly more of a personality change. They will be more violent, sometimes more aggressive. They will have hallucination and all. So we call it behavior variant of the Alzheimer's. So this become difficult for a caregiver also to take care of such people. but they don't do it deliberately. It just happens because in this variant, what happens? Our frontal lobe, which maintains our social etiquette, it will be affected. So my social behavior, I know how to talk, I know where to sit, uh, how much aggression I should show, how much love I should show, or I should how to where when should I use washroom and all. So these are my social manners. They will be predominantly affected in these people in a very early stage of disease. So it becomes so we have to give some certain medicines to control this behavior because ultimately it affects them also and also the family. So this behavioral variant of dementia. So most of the people they come to us like I have forgetfulness. So generally these are not people they are having dementia. So whenever a classical person with a dementia will be like family will come, they will say no, he's forgetting, and he person will deny that I am forgetting because he is actually forgetting what he forgets. So this is a classical scenario when we get a person, we diagnose a person will having a dementia. Sometimes some people come with a voluntary consultation low. I think I am forgetting. So actually, this is most of the time they don't turn out to be having dementia or any cognitive impairment. Most of the time they have some inattention and difficulty in the formation of registration and new memory, but it is not dementia. In Alzheimer disease, early, mild, there are stages: mild, moderate, severe, and then advanced stage also. In mild dementia, in most of the time, family member will not notice. But if sometimes we do some cognitive functional testing, we notice that for his age, which his education and which his orientation, he should perform these activities and he is not able to perform. That's how we label them mild, moderate, or severe. So in mild stage, subtle changes in the personality, subtle changes in the cognition will be detected on testing. Sometimes in day-to-day functioning. So they generally progress and they are slowly worsening ultimately over the period of few next month or years. And we when we diagnose and we label mild, we give medicines, and our medicines they do work in mild to moderate state very beautifully, and we see good memory improvement. So our aim is to diagnose the Alzheimer's or any dementia in early stage so that we can improve their mental capability by giving our medicines. We have good medicines. In moderate dementia, moderate stage, they different domains and functions are affected. Then they have difficulty in maintaining the language, means some naming problem. Then suppose a question is given, they will have difficult to solve it. We call it reasoning. Then they have a problem in sensory processing, conscious thought process. So these will be affected. Over the period of time, memory will get worse and they may forget or they may find difficult to name close family friends or our any new person. Suppose they're supposed to tell the name, they may not tell the name. In severe dementia, actually, they are completely dependent, or most of their day-to-day activity are completely dependent, and self-care also may not be possible for these individuals, and memory function is very poor. And at the very late part of dementia, generally they become bedbound because ultimately other problems also they develop, like they develop Parkinson features, they develop some other joint related problem. And as the dementia advances, their self care is also not good, so there is lots of muscle mass. uh, they are prone for infection because of lack of immunity. And so severe dementia, generally the elderly, they become bedbound. How we diagnose dementia? Dementia is diagnosed by clinical tests. We diagnose clinically most of the time. Okay, this is a Alzheimer's disease, and rarely we need some test. We do test not to diagnose Alzheimer's. We do test to rule out other mimics or other conditions where memory loss is very common. So we some person elderly come with a features of dementia. We do some bedside clinical test, or in OPD also we do some test. We call it MMSE. So they have different parameters here. Is very we have to quantify actually. As a neurologist, I should know, like I am giving medicine, how the memory is improving or not. So we need a score. So this MMSE is a score basically. There are different domains we test by simple questioning, and sometimes we need to write or draw something, and we calculate a score. And according to the age, according to the education, we consider it significant or not significant, and we mention it, and we start medicines. And in follow-up visit, 3 months, 6 months, we keep checking the score whether it is improving or not. So that's how we monitor the progression and severity of the Alzheimer's. Then there are a lot of other scores we have, and in sometimes very early dementia, we have to do detailed cognitive testing to diagnose the hidden domains affected. Then we do brain imaging, like MRI, sometimes CT scan. Sometimes MRI may not be feasible in some elderly, so we have to do CT scan. And we rule out other mimics of the Alzheimer's. This is how they do the testing. This is one of the testing from MNC. This is a pentagon basically. So they're supposed to draw this type of pentagon, but sometimes their analysis is not possible, not proper. So you can see in down image, they are making the square. It's not like pentagon. And sometimes they find difficult. In advanced stage, you will find two different squares they are drawing, because they see the picture like that and they try to analyze. Similar things are situation is applicable for his other day-to-day activity of other functioning domains also. Sometimes we ask them to draw clock. So they do like this. Sometimes they will misplace. Sometimes they will not able to do it. And sometimes, suppose I tell them like you draw clock and set a time 10 past 10, they may set 11 past 10, because they don't register what I'm telling, or they are forgetting part of the information. In first example, you are saying that after telling 10 by 10:20, he's saying 11:20. And also you can see some he is not centering into the center, that he's not starting the clock in the center. It is a spatial disorientation. One more thing, in dementia, we see that there is a geographical disorientation. So sometimes they go out, elderly people with dementia. Sometimes the family don't know that they have dementia. They can't come back. They just simply can't come back. They can't find a way back to home because the geographical memory disorientation. So they find difficult to remember the path. That is day-to-day activity. Suppose they are living in this society for almost 10 years and they are going for maybe half kilometer or so and they can't come back. So this happens in Alzheimer's quite frequently. We call it geographical disorientation. In advanced stage of dementia, sometimes they find difficult to locate the bathrooms also at night. So they get confused and sometimes they may avoid some other place. So they don't do it deliberately, it just happens. One more phenomena in elderly, you must have seen that elderly, they remain okay in morning hours, and evening hours they become slightly disoriented and all, more disoriented. We call it sundowning effect. Because in in morning, they have broad daylight and they have a lot of orientation, at least because of with the help of the sunlight or any light, they know that where are the things and they know about the timing and all. But in evening hours, they become confused. So we call it, and they get more agitated in evening hours. So we call it sundowning phenomena in dementia. Now, how do we manage? Management is not only medicines. Management is a multifaceted, right from the diet, then taking care there, physiotherapy, proper care, and social aspects, and then comes the medicinal medicines. So we have memory boosters. They are simple memory boosters. We start, and according to the tolerance, we gradually increase the dose. They are very effective in early and moderate stage. In severe stage, it becomes difficult to control the symptoms. Sometimes, as I mentioned, they may have behavioral issues, forgetfulness. Along with forgetfulness, they may have antisocial behavior. They may be aggressive. There may be disturbed sleep. So we have to give antipsychotics, sometimes mood elevators. They may have low mood, depressed mood. So we have to give mood elevators. At times, sleeping pill. Generally, we avoid all these medicines, but sometimes we have to use them because sometimes we have to give them. Now, there are certain molecules approved by FDA, but they are of doubtful benefit. They're supposed to stop the progression, but they are not widely used in clinical practice because still the efficacy is in doubt. So let's see. In future, we may get some molecule because, as I mentioned, extensive research is going on. So some monoclonal antibodies research is going on actually, and there are certain approved also, but we have not found any significant improvement. So we are not using it as of now. Now coming to the diet, so they should maintain their diet. As they are not able to take care, it's family's responsibility to take care of their diet. So fish, olive oils, avocados, then fruits, they are the rich fruits of antioxidant, fibers, vegetables, nuts, beans, whole grains. Generally, it is recommended in Alzheimer's people or in any elderly, because ultimately these are the good sources of antioxidant proteins. They will progress, they will prevent the progression of the any dementia or any other chronic illness. So in oil, we should be careful that we should take more of a unsaturated fatty acid, oil containing unsaturated fatty acids. Oil more with a saturated fatty acid like coconut oil, groundnut oil, they are not good for your heart or any other, because monosaturated fatty acid is not good for us. So Alzheimer's people, they need family support. They need family should understand, because sometimes the person come with consultation. We also educate the family, because sometimes they don't know ki, that he's we generally tell them whatever he's doing, he's not doing intentionally. It just happens. So you should be careful. Like suppose somebody is giving different answer, or he's not good to you, not talking properly, or he's arrogant. So he's not deliberately doing it. So you should take care. You should consider his age and his dementia, and you should support him in always whatever. So this is very important. Sometimes with behavioral problems, and we have seen the caregiver burnout also, but we have to educate them also how to take care. Then there are now, as I mentioned, sometimes they forget, they can't come back once go out. So nowadays there are devices. Sometimes so one of the Indian student, they have developed one, I would say, a ring where you can wear the ring, and it is connected GPS device actually. So in souls, or sometimes you can give them the smartwatch, so that once they go out, it will be easy for you to track them. So that's how we can use the technology to take care of this problem. So Alzheimer's disease is a common. Alzheimer's disease, though it is not completely treatable, but definitely it is modifiable. We have good medicines, proper diagnosis, early diagnosis, and we start medicine. We can definitely improve the functional quality of the life of people with having dementia. And whenever any near dear one, you are finding that he's suffering from dementia, you should consult your neurologist or doctor. They will definitely start some memory boosters, which will definitely help them. And I will stop here. If you have any questions, we can answer.
Thank you, Doctor. Thank you for a very detailed presentation.
Thank you.
We have a question from Mr. Narendra Shah, who's 73, but I guess you've answered about what preventive.
One thing I want to answer, I want to add here. See, we have seen that dementia features, they are occur very late. Suppose a person is having a learned person, educated, highly functioning memory, like suppose he is having PhD, another person who is illiterate, elderly. So suppose there is a significant memory loss, significant neuron loss, but as he is having higher mental functioning, arithmetic capacity, his dementia features will come very later. So lack of education, lack of arithmetic mental capacity. So that is also one of the, I would say, they will develop feature of dementia late in there as compared to those who are not educated. So that's we have noticed. Yeah. One more thing, in Indian subcontinent, they have said that we have so much population, and why we don't have dementia so many. So I just was reading across, so I came to across that in our Indian diet there is turmeric. So they say that may be one of the cause that prevents the dementia in our population. I don't know. They don't have any solid evidence data for that, but they say that. But maybe it is undiagnosed dementia in Indian population than any preventive thing into the diet.
Right. Thank you, Doctor. There's a question which has come in, which is absent-mindedness an indicator that one could be having dementia at some point?
Okay. So, as I mentioned, absent-mindedness actually is a inattention. Most of the consultation, they come, young patient, young people also, or elderly also, they come. So they think that they have dementia, but actually we find that it is not dementia, it is inattention. So my memory will not form immediately. First step of memory formation is attention. Sustained attention is called as concentration. Then there is a registration, and then there is a memory formation. Suppose I am not paying attention to something, so my memory will not, my brain will not register that thing, and the memory will not form. So rather than dementia, I will say ki I have inattention problem. Now, why there is inattention? Suppose I have some pain, sometimes I have stressed out or something, there are a lot of things happening in my mind. So we think that we are paying attention, but it is not 100% attention. Part of that thing is already not registered in first step. How can memory will form? So this absent-minded most of the time maybe a part of the early like misplacement of the thing. They can occur in dementia early also, but most of the time it is not dementia, it is a inattention.
Right. We have another question which is here, which I've got by SMS, saying, Doctor, uh, a lot of people have, and especially amongst the younger lot of people, they have what is called attention deficit disorder.
Yeah.
Is that anything to worry about, that a person having attention deficit disorder who could be getting dementia or Alzheimer's later on?
No, as such, no, not. See, attention deficit disorder generally we diagnose in children. ADHD we call it. Attention deficit hyperactive. The children, they can't sit in a one place and they are having
Right.
focusing attention. So they are, actually there is no risk of dementia in such children. Sometimes they improve with time also.
Right. We have a question from Mr. Lakshmi Narayan, who says he's age 69 and he has an amazing memory. He wrote, in fact, recently wrote a book, This Day, That Year, and he plans to write something on cricket. Earlier, it was on movies. He says, when I sit down to do exercises in the morning, I'm unable to recall if I finished a specific stretching exercise or what happened in a recent cricket match. This is the opposite of recency effect. Is this a symptom of Alzheimer's, or is it just due to a information overload?
It can be both. I would first consider it as an information overload. But definitely, as you mentioned, you can remember the past, like other matches and all, and recent you are forgetting. So definitely, you need to please consult a doctor. Actually, there is a recent memory loss or inattention causing the problems.
Right.
Yeah.
There's a few questions which have come in. There's Mr. Satish Kalia is asking for differentiation between dementia and Alzheimer. And
Okay. Dementia, see, dementia is a broad category. Alzheimer's is part of the dementia. Like I have fever. Fever is a broad category. I can have viral fever, malarial, typhoid. So there are different types of the fever, right? Similarly, Alzheimer's is one of the type of dementia. There are a lot of dementias. So Alzheimer is one of them. So that is the difference.
Right. Very well explained. Thank you, Doctor. We have Mr. Prakash Jaktiani asking, will Parkinson's cause dementia?
Okay. See, plain Parkinson immediately will not cause dementia, but in advanced Parkinson, again, Parkinson is also neurodegenerative problem. There is predominantly a problem with the movements and all. But ultimately, with advanced, I will say very advanced Parkinson, they will have some dementia features. We call it Parkinson disease with dementia. In early or normal Parkinson generally doesn't occur very early. It occurs very late. Very late means maybe second decade, third decade. You will see.
Right. Doctor, we have two more questions. One is from Marjorie Fernandez. The question is, can lack of sleep for several years lead to dementia?
See, sleep is required. Lack of sleep will cause other problems. Like, see, it will not directly cause to neurodegeneration, but it will increase the risk factor. Like I mentioned, suppose I'm not sleeping properly. Ultimately, it will give right to impair your blood sugar level. It will impair your blood pressure, sugar. So ultimately, they will give right to increase of vascular risk factors, and ultimately, you may increase the risk of dementia. But directly, they are not related. But this how we can correlate with the lack of sleep and getting the dementias.
Right. Doctor, we have a question which is not on the topic that we have today, but since he's a regular over here, and even if he wasn't regular, I would have asked this question. He's Mr. Suresh Ghate, who's 72, His question
Mhm.
is, how and why um, does one face vertigo problems? Is it related to the brain? And what measures to be taken to the recurrence? If you can answer in 1 minute, and
Yeah,
we'll
yeah, sure.
that.
See, vertigo is very common. Vertigo is imbalance. As I mentioned, vertigo is a symptom. Vertigo is not a diagnosis. Once you have vertigo, you can have different type of this manifestation. It can be spinning sensation. It can be imbalance. There are a lot of causes. Most common cause of vertigo is disturbance in your balancing mechanism, which is into internal ear. So most of the forms of vertigo, they are harmless. We call it positional vertigo. Moment you change your position, you get vertigo because of disturbance in your balancing apparatus. At times, vertigo can be of central or brain related. So we diagnose it. And sometimes suppose stroke is there into the balancing apparatus in the brain, then you can have vertigo. So ultimately, most of the time, I would say 90-95% time, it is a simple vertigo. And with positional changes, you will have more severe of the vertigo. So it just occurs in a young patient also it occurs. Sometimes elderly, it is more common.
Right. Doctor, we have one question, which is, I don't know whether it's a question or whether he's saying,
Acquired, yeah, yeah. I
let
should
me
have.
just ask,
See, sometimes, yeah,
by
yeah.
singing or
Sometimes we,
dancing, can one improve uh, uh, Alzheimer's if one has a Alzheimer's issue?
rather than, yeah, you can obviously, rather than, I will not say, I will generally be recommend Sudokus and all that arithmetic games to Alzheimer's people. They will improve. Singing and dancing will definitely may help because ultimately they will improve. They need some part of memory and ultimately, so generally we recommend Sudokus and mathematics games for early form of dementias if they can perform.
Doctor, tending to forget names, that's not a worry, right?
No, actually, it can be. Sometimes it is like inattention, difficulty registering name, but we call it anomia. And as I mentioned in presentation, anomia is also very common in Alzheimer's. Not all people with anomia means difficulty in naming will have Alzheimer's, but that is one of the features, can be a feature. Isolated anomia may not be, but anomia means naming problem with other features can be Alzheimer's.
Doctor, one final question. Sorry, I know we are
No
exceeded
problem.
time.
We are okay with that. No, we
Just
are
one
here and I
question.
will share.
Uh,
Yeah.
this is an anonymous person who said, who's complimented your
Yeah,
presentation.
yeah, acquired. Yeah, so actually, sorry, I
Can
used
you
my
put off your
this.
screen share? We can see you bigger. Can you put off your screen share? I just didn't realize, and just a screen share. If you can put it off, stop screen share.
Okay, just a minute.
Yeah, great, super.
So they have. I think I just want to answer his query. It's acquired means this is our for us. It is a common terminology. I should have elaborate. Acquired means they are not present since birth. With exposure to the environment and with aging, with interplay with the different factors, you start developing the symptoms. We call it acquired.
Right. Doctor, thank you very much for an amazing presentation and for spending so much time here today. But I'm going to request you to stay on for a minute. I'm going to ask our producer to make a small presentation, show us a video of the latest issue of Seniors Today magazine, which is just out today. 15th
Yeah.
of the issue is out. We've completed 60. This is our 60th issue. Dave, can you play the presentation? Would like to see it. Our cover story is written by the very well-known Urvi Piramal, who's written a story on the Arctic. She went to the Arctic and she's spoken about that. We have another article, and Doctor, this would interest you. We have an article by Dr. Rajan Bhosle. Dr. Rajan Bhosle is head of the sexology department at the KEM hospital. So he had written our cover story last year, and he has written the frequently unanswered questions. If you call it instead of FAQs, it is the FUQs, and he has sent us that. And there are a host of other articles which exist, which are there in our magazine. For instance, we have an article on the rains. We have a war in history article. We have fun and wacky activities, and we always have something on cinema or entertainment. And in this issue of the magazine, we have the award-winning writer Deepa Gehlot talking about how we've had so many films over the years which are on the Tawaif, and this is in the context of the Hiramandi series on Netflix. So she's written the piece. So do enjoy the magazine. It is, as always, available free of cost on seniorstoday.in, and do have a look. And those of you who would like to attend our health webinars, you can pre-register. All the links that are there, these are put up every time. We will be back once again next Saturday, which is July 22nd at 5 p.m. with another session of Health Live at Seniors Today. Thank you very much, and do take care of yourself. And thank you very much, Dr. Vishal Chafale, for this, and to the team at Apollo Hospital for facilitating this. Thank you.
Thank you. Okay.
Subscribe now and press the bell icon. Never miss an update.